Dear Professor, both of you, Professor Renzo is our first lecturer, and I will speak in Serbian language, but Professor Renzo is our friend and the person that has lightened our way, not only in clinical, but on scientific way of research. And he is well known in all parts of perinatal medicine, obstetrical medicine, and I will tell in Serbian language, and you will have another way of that, but for our people, I will tell in Serbian what are your benefits in our field. Profesor Giancarlo Di Renzo je jedan od osnivača perinatalne medicine. On je inače dugo vremena vodio svetsku organizaciju ginekologa obstetričara, FIGO, bio je generalni sekretar. Dan danas je on direktor univerziteta, u stvari da kažem on je sinonim univerziteta Peruđe i jedan od osnivača ne samo perinatalne medicine, već onoga što posebno impresionira nas, inovacija u perinatalnoj medicini. Jedan od njegovih istraživanja nije vezan samo za prenatalnu dijagnostiku, za organizaciju, za maturaciju fetusa, načine na koji se borimo sa prevremenim porođajem, sa primenom terapija, ali isto tako jedan veliki značaj njegov je u dijagnostici monoklonalnih antitela, u dijagnostici terapiji malignih bolesti, kao i, nećete verovati, u 3D printingu u medicini. So, Professor, I would now ask you to give us your lecture, and thank you very much.
Dobar dan, buongiorno, good morning, thank you very much, and very nice presentation from both of you, and very happy to be here after a while. So this pandemic has make us see each other in 2 dimensions for a long time, you know, through the webinars and television. Now, finally, we can see each other in 3-4 dimensions, also moving around. And this is something different, okay? I was asked to come and talk a little bit about this topic, the shortening of pregnancy. What does it mean, shortening of pregnancy? Shortening of pregnancy, practically, is when a pregnancy ends earlier, okay? And if it's too early, before 22 weeks, according to the WHO criteria, it's called miscarriage. If it's after, until term, is called preterm birth. The difference is substantial, because when we talk about miscarriage, we don't think that there is any possibility for the fetus to survive. So is a dead practically individual. While when we talk about prematurity, even though the difference is maybe only 1 minute from 21 weeks, 6 days, 23 hours, 59 minutes, and then 1 minute later, we think that it is capable to survive. So it's a newborn, okay? So it's a preterm newborn. But pregnancy is a continuum, so it's very difficult to divide the two. And our challenge is mainly between, you know, the window of shadow there is between 20 to 26 weeks, in which it's difficult to take any decision, to get a result, and so on. But let's say that beside this premise, that we'll talk later, and we differentiated 2 topics, I want to introduce something that is very important to understand what I will present today, the result I will present today. When now we are addressing any clinical management, any therapeutics, any drugs, we rely on the clinical trials, okay? What is something that we receive from literature, that we read mainly in English-speaking journals around the world. And there are several degrees of evidence according to this. Many, many years ago, it was the ideas or the opinion of a very important doctor to make everybody to follow the same things. Then there was the case series, let's say in the 18th, 19th century, people were bringing, I did 10 cases with this and I was successful. And everybody do the same. And nowadays we don't believe it to this, even to cohort study. We need a randomized control trial, okay? But it's not easy to make a randomized control trial. And also many of these randomized control trials are very small number. Therefore, statisticians and doctors, investigators created the systematic review or the meta-analysis. They put together, you know, many of these patients coming from all over the world, it doesn't matter, but having more or less the same treatment, and they get some statistical significance. This has been translated in the evidence base, and we have our Bible, which is the Cochrane. I don't know if you use the Cochrane, but it's our Bible. We read the Cochrane, and we think that what Cochrane says is the truth, and we have to follow. But are we sure that when we put together all these data are really homogenizable in the sense that I can put a patient coming from United States, which have been in hospital for that reason, similar reason in Europe or in Asia, and I can put all together and get meaningful result. In order to overcome this, there are some criteria which have been selected by investigators saying, okay, if I have randomization, if I have allocation, if I have the same target, same objective, so on, I have a green light in every of the study which I consider, then it's quite possible that my meta-analysis is meaningful. But, you know, in order to obtain this data, if you look at the meta-analysis systematic review, which has been published in the last 10 years, all the authors start from 1,000 studies and arrive only to select 5, because it's impossible to get the similar items to be evaluated. And if I have this kind of differences, in the sense that probably the design, the protocol, the same, you know, items which I showed before in green, they are in red, then it's very, very difficult to homogenize the study and to get meaningful results. Unfortunately, all the research around the world, in order to publish, they publish also these kind of things. And if there is a poor methodological quality, the final message may be good from the point of view of statistics. It looks okay because statistically significant is very nice to tell in order to convince you to do something. But they are not meaningful is to put together pears and apples, as I call. I mean, when we do a smoothie, okay, we put different fruits and the flavor looks nice, but they are different, okay? They are not the same things. And this happens particularly, for instance, some studies which are related to the topic which I tell you today. And I want to make this premise so you understand which I will be very critical in some of these studies. For instance, this is a meta-analysis. We put together the use of some progestogens or progesterone used for 2 days, the other for 5 days. They come to some result. By the way, the results are not so meaningful because they are crossing the line of 1, and in statistics, this is not statistically significant, but they say in any case, oh, there is a good result, a good advantage to use this drug for, in this case, for miscarriage. But I think that only one study is in green, all the other have major bias. So this is not something that we can take. So again, mixing a lot of studies, which, for instance, go from the 50s even, 1950, 70 years ago, to nowadays, in order to get some, proof that what you're saying or your idea is sustained is very dangerous. I will show you for the two parts of my presentation how many of these studies are wrong in their conclusion. Okay, now let's talk the first part. As I said, miscarriage can be treated, miscarriage. So a patient comes to our office with a pain, with some bleeding, with a situation that pregnancy may not continue, and a patient which have an history of more than 2 miscarriages. Nowadays we call recurrent when it's more than 2 in generally. Also because the age of a population for the first pregnancy is switching toward the late reproductive time, and therefore we are more pressure to do something to this kind of people. 1 every 4 women experience this kind of situation in pregnancy, but the consequences, which we don't think sometimes, are very big, not just because maybe that the pregnancy is lost, but there is a risk of major depression in this woman. It is not something that happens easily. As you can see here, that if I take 3 women which have a treated miscarriage, 1 of 3 usually is going not to continue pregnancy, just as general statistics. The first things that we have to think is that what we are doing and what we are managing for a patient having this kind of problems is applicable very little on general population, because every woman, every sample as of human beings is so heterogeneous that it's very difficult to make something that is equal for everybody. The second other premise which I would like to underline is when we talk about miscarriage or treated miscarriage, we are speaking about a clinical loss, which is a minority of all the loss that a woman experiences, because the majority are preclinical, pre-implantation loss, which are very difficult to determine, but it has been demonstrated from a comparison with animal study. And we start, seeing the loss when at least not only there is a test positive, but we can identify a sac or an embryo and so on. And of course, we make differences. Now, if we look at the frequency of these, you see that the pre-implantation is almost half of all the losses. And when we go to the preclinical or clinical, there are much less. And more we go over with the pregnancy as age of gestation, we have a less percentage of loss. So the majority of loss at the beginning. The second axiom that we know is that the more loss you experience, more the chance, if you don't do anything, that they continue to lose your pregnancy. I mean, it's not something that stops easily. The reasons are many. And of course, the difference is if you had at least between 1 pregnancy and the other, 1 live birth, because this changes the statistics. But if you don't have any live birth, the number of abortions you can have continues to increase. And you see, this is a very recent analysis that we perform and publish in American Journal. And you can see on the other side, the risk of recurrence that you have a miscarriage from 2 to 3 to 4 to 9 to 10 times, according to the number of miscarriages one woman have, according to the number of pregnancy. The epidemiology of this kind of losses, let's say that we, of course, now determine mainly the clinical ones, is related, as you know, to some risk factors which are evident to everybody: the age of the mother, the lifestyle, especially if you smoke, you abuse alcohol, you're abusing some nutrients which are not nutrients like caffeine, for instance, But we forget that a very consistent part of abortion may depend by environmental factors. And unfortunately, this is more frequent than we may think. What I'm saying here is that in some occasion, whatever we do is impossible to avoid if we don't avoid the environment or we change the environment around that particular woman or that particular population woman. I show only one data, very recent, of a compound that almost everybody has in the house because it's, for instance, a BPA, which is a substance which is associated to the anti-inflammation. So is added to our furniture in order to avoid, for instance, that it takes fire, it refrain from fire. If I have this furniture at home, and of course, I absorb by several routes, by contact, by inhaling and so on, and I have the presence of this compound in the blood, according to the number of the concentration of compound in the blood, I will have more and more risk of miscarriage. And of course, the risk of miscarriage that we have is the one here, the euploid one. So with a fetus which is normal, which is has not something to do with chromosomal abnormalities, is because these compounds are toxic, are called toxic chemicals, and they are very frequent. I would like to say this because there is now more and more attention paid to these problems, especially related to the continuation of pregnancy. Therefore, even though we can do a good workup of a patient, you should understand that it's not easy to find out all the possible factors. And one of the variables is the environment. Generally, when you go in any textbook and you study what are the reasons for an abortion, you have more or less an ensemble of factors: genetic, anatomic, endocrine, infectious, immunologic, and several others put together. But what are the real important ones? If we look at, for instance, the sporadic miscarriage, we know very well that 60 to 70% of cases due to genetic or some problems in the fetus embryo. But if we go to increase the number of miscarriages women experience, then you can see that the genetic has much less value compared to other reasons, infectious, immunological, and so on. For instance, this is a statistic that we did already 20 years ago in more or less 500 couples having recurrent miscarriage. And you can see that more you have abortion, more there are immunovascular pathology behind that you can demonstrate in your workup. Briefly, I want to address 2 or 3 aspects because they are important, because there are very important news about these aspects. Okay, when we talk about genetic, as I said, the treatment miscarriage and probably the miscarriage single sporadic, as we say, recognize usually an aneuploidy in the fetus. When we did an essay with a more sophisticated tools that we have, and microarray and so on, in order to be very selective in the evaluation of the embryo, in order to understand if really there is something wrong in the chromosomes, you can see that with this methodology, we have 54% of sporadic abortion, which recognize abnormalities in the DNA of the embryo. You can see that the abnormalities is mainly aneuploidies or trisomy, but also abnormalities of the sex chromosome, as you can see, and more rarely translocation. But the real message that we have to get from all these studies is that the more we have abortion, the more the euploid miscarriage is in percentage is more relevant, which means that we cannot change too much the percentage of aneuploidy, but when we have more abortion, then, and of course we cannot do anything if we have a chromosomal abnormalities, but if we have more abortion, other causes are, you know, the main risk factors. And these are amenable for, of course, prevention. This means that I cannot do too much, and especially I have to establish studies when I do studies on miscarriage, which should consider a consistent number of cases, because whatever I do, 30, 20, 25, 30% of cases, I cannot do anything. Is a basis which I can treat in any case, and but they are chromosomal abnormalities, I can do anything. I will show more later what does it mean. The second concept is the, very recently, you know, everybody is speaking about thrombophilia, immunovascular disorder, and so on. And we know that we have a congenital thrombophilia, acquired thrombophilia. There are so many, and the aspects are very confused. But what are really the ones that have been associated consistently by the epidemiology to early pregnancy loss? As you can see here, the most is an acquired thrombophilia, which is lupus, okay, anticoagulant, or the factor V laden. But you see, for instance, the homozygosity for metatetrahydrofolate is not being associated. It's something that everybody tried to treat and giving heparin even, but there is no need, because now we are quite sure that it doesn't work. So the MTHFR mutation is not so important as we thought before. What is really important is to try to recognize if there is an antiphospholipid syndrome, so the so-called lupus, because by itself, it can explain 9 to 10% all abortion which are repeated, okay? But of course, we have to do a very good diagnosis. There is some guidelines which have been established by rheumatologists how to diagnose antiphospholipid syndrome. And remember, when we have diagnosed that there is a thrombophilia in the background, this lady, we should not give only heparin, but association with low also aspirin, because it's only the association between the two which make it different in the results, okay? Giving only one or the other is not enough. This has been demonstrated very well. I would say that this Cochrane review is very old, it's already 15 years old, but has been unchanged in the last 15 years, so it's been only confirmed. The third big area is the endocrine factors. So many aspects of endocrinology in women, particularly reproductive age, has been linked to the risk that pregnancy cannot continue. For instance, thyroid dysfunction, for instance, pre-gestational diabetes, so diabetes before, or metabolic syndrome. We have also to consider endometriosis. Endometriosis is in any case related to an increased risk of abortion. Either endometriosis is solved by surgery or is not solved too well by surgery. There is an increased risk because endometriosis is changing the autoimmunity of a woman. Okay, the inflammatory status of a woman with endometriosis is altered in any case. So we have more risk. And then, of course, the luteal phase defect that we'll talk a little bit more. When we need to make a workup, therefore, to these women, for several reasons, we need to evaluate the uterine cavity, because there can be, you know, the so-called submucous fibroma or polyps or so on, or alteration in the cavity. Then, however, we may concentrate in immunological tests for the lupus or for endocrinological screening, particularly for thyroid and for the diabetes. And we have to look at the diet and lifestyles. Paternal karyotype has some role, but nowadays in development, there are two major areas, which I don't discuss because it's too complicated at the moment, also because those who are investigating are not clear what is important. So the chromosome microarray analysis, which I showed just one study on 8,000 cases, and the endometrial array transcriptomics, or the microbiome of endometrium, which is another aspect which is still under investigation. As we talk about endocrinology and luteal phase defect, of course, it comes about the story of progesterone. Progesterone, of course, is a very important hormone. By the way, maybe not many of you know that it was not called progesterone from the beginning. It takes 10 years to be called progesterone because it was called in several ways, lutesterone and something like that. But at the end, in science, so you see, more than 85 years ago, 4 people decide to call progesterone, which is an acronym. It means progestation steroid ketone, okay? Which is applying the formula, which is steroid substance with a ketone body, and progestation, because the first study was only demonstrated that maintained pregnancy, okay? The first person, the first group of investigators which proposed the use of progesterone for sustaining the pregnancy and for avoid abortion, which has been spread everywhere, was the group of Gian Seager-Jones. You see how many years ago? It was 1949 when she made a first study showing that giving progesterone, we may avoid abortion. Many years ago. But I should say that Georgiana Seager-Jones didn't know very well the mechanism of progesterone. They were only based on some experiment made in animals, and it was only, by the way, later than Seager-Jones, that progesterone was available for gastrointestinal or mucosal absorbers, because until that time, until the 70s, progesterone was available only by intramuscular route, because it was not absorbed well by the gastrointestinal tract. And there was only the macronization to make the difference in the late 70s. So at the beginning, it was very painful for these women to receive this injection of progesterone in an oily vehicle, which gave a lot of troubles, by the way, I'll mention in a moment. And then after the macronization, it was the possibility of administering more easily progesterone. But in fact, if you think progesterone can be administered by any route, the problem is that it is not the same effect by the route. According to the route, progesterone may be metabolized in different metabolites which have different action, okay? And I want to just summarize this. For instance, if I give by oral route, I have 2 enzymes which metabolize progesterone in a compound which is not metabolized by other route, which is allopregnanolone. Allopregnanolone interacts with the GABA system and have a potent effect in the central nervous system. So if I give by oral route, may I have dizziness, I can be sleepy, I can be less anxious, and so on. Effect which I don't have if I give from transdermal route, for instance, when I give transdermal route for the breast, for instance, because there is some effect, a optimal concentration in the breast tissue. If I give by intramuscular route, the turnover of progesterone is quite different. It may have a lot of other effects, okay, and also reach also supraphysiological concentration, which sometimes are completely unuseful. So we have to be very careful when we give intramuscular progesterone, because it may reach very high concentration of blood. And of course, a vaginal route, which has not the enzyme of the gastrointestinal mucosa, so practically is not converted in allopregnanolone. Therefore, there is no effect on the brain system if I give by mucosa route or rectal route. You see that according to when I give this compound, I may have different effects. And the different mechanism of absorption by the vaginal route has been elucidated in the last only 15, 20 years, probably through the transfer by lymphatic vessels, or some veins, or even the intraluminal passage and so on. So the question why, if I give progesterone by vaginal route, I get optimal concentration in the pelvic area, has been studied with a few studies, which has mainly shown that after 4 hours, all the receptors of progesterone in the pelvic area are saturated by the mucosal absorption. What is important to know, however, that given by vaginal route, I can have some concentration in the blood, okay? But the amount that I have to give in order to reach the concentration which are found to be useful to maintain pregnancy, not only so the saturation of the effect, but also a general effect, because progesterone has a lot of effects that we'll see in a moment, need at least to have 600 milligrams, not less, because with the 600 milligrams, we have the famous value, more than 10 nanogram milliliter in the plasma level, steady, maintained at least for 14, 16 hours, which are the amount which is recognized to be the best for maintaining pregnancy. So we cannot give a little progesterone amount by vaginal route, but substantial high concentration. And this was the difference of many of the last studies which has been done in changing by giving only 100, 200 milligrams to giving 800 milligrams, and this makes the difference and get the result. Now, the study about how progesterone works has been elucidated only in the last 20 years, I should say. You know that in order to have a successful pregnancy, there should be a switch in the immunotolerance of the mother, okay? This switch particularly is related to the lymphocytes, Th1 versus Th2. If I want to maintain the same level, that is not good for pregnancy, because what we should have is a switch toward Th2, which is an anti-inflammatory environment which favor the pregnancy to implant. If, however, I maintain the same level or I go even in more Th1 predominance, I will have still a pro-inflammatory activity. And this explains why in some underlying disease of a woman, this is something that, for instance, obesity, the pro-inflammatory remain with the cytokines which are not favoring implantation and so on. Of course, when I start the production of hormones like ACG, the corpus luteum continue to produce progesterone, and the progesterone has mainly free action at the beginning in favor of implantation. It stops prostaglandin, is an anti-prostaglandin drug, which is very important because prostaglandin otherwise are against the pregnancy. Then it favors angiogenesis, it favors the VEGF factors and so on. And finally, it has a lot of action in the immune system of the mother, protecting the implantation. Practically, the mother should accept a transplant, which is an allotransplant, not similar to any part of her body, and accept this transplant, which is very aggressive, by the way, because you want to enter in the, the body of the mother. In order to do this, progesterone induces a protein, which is called PIBF, progesterone-induced blocking factor, produced by lymphocyte, okay? And this protein, if is produced in enough amount, change this immunotolerance in favor of the pregnancy. And it has been demonstrated, if I give antibodies who block the production of this protein, like with the mifepristone, or I give antibodies against this protein, I get abortion. Okay, this is the mechanism by which. So we summarize all this data. You see, there was a summary of no more than 10 years ago that was possible to make all these put together. Very recently, we edited a number of British medical journals. You can download free, by the way, in which there is all the description of action of progesterone. This was published last year. And you can see that all the action of progesterone, particularly already in favoring the changes of endometrium in order to attract the blastocyst to stop, like a little, let's say, a satellite which is going around, and then he has to find. But there is a window opportunity, very little window opportunity for implantation in the body of a woman. Few days only, few days in which there should be changes in the endometrium we call decidualization, but there are changes which are crucial in order that this satellite, which is the blastocyst, arrives, stop, and enter in the body. And then all the rest is made by progesterone as well, improving blood flow, blocking prostaglandin, reducing uterine contractility, so many, many actions. Now, it is important the concentration of progesterone to understand if pregnancy is continuing or not. I would say that I told you, beside the famous cutoff of 10, it's very difficult because progesterone has a circadian rhythm in the woman. It is more elevated, for instance, in the evening and less in the morning. So when we withdraw the blood in the morning, maybe that the value of progesterone is low, and we may give a false positive result, thinking that there is something wrong, while if we measure in the evening, it's different. So the fact that we measure progesterone has not found a wide consensus to check, if pregnancy continue or no. But of course, if we have values lower than 10, this has been associated with high risk that pregnancy does continue. Now, the fact that to give progesterone, and I come to my first premise about the randomized meta-analysis study, is that they mix progesterone with progestogens, which are drugs which have maybe an action on progesterone, but not all the action on progesterone. They don't have the same route of the administration, so on. And some of the studies, which at the beginning were favoring the use of progesterone for instance, recurrent miscarriage, were dating 53, 64, and the number of cases total was 90. So how you can base a suggestion of a clinical intervention on 90 cases altogether based on data of 1953? You can imagine that our investigators sometimes are a little bit fancy. You see the number of participants very low and so on. Then came another study. Before 2019, we have this kind of study, around 400 total, with a mix of every kind of progesterone, progestogen, dihydrogesterone, medroxyprogesterone acetate, hydroxyprogesterone, and so on. And they put together and they say, it works, giving progestogens works. Fortunately, some investigators coming from UK, they provide two very big trials. One is called Promise, and the other is called Prism, but it doesn't mean anything. Trial which have completely changed our view now of the effect of progesterone for the miscarriage. And these have been kept by all the international and national societies which are dealing with reproduction and incorporated in their guidelines, okay? These are more or less all the studies. The population of the first study was 825 cases, which altogether is the double of all the meta-analyses which have been produced before, just one study. These were an intervention on women with recurrent miscarriage, and you see here that the first things to note is the high dosage of progesterone they gave, okay, against, of course, placebo. This study has shown that more we have abortion before, more there is success in using progesterone. This is in keeping with the slide I showed before. Progesterone probably doesn't do too much when we have a high chromosome defect at the beginning, but when we increase the number of miscarriage and there are other factors which intervene, progesterone may have its effects. The second study was on addressing very normal problem that we have in our office every day. A woman which is coming bleeding in early pregnancy. The PRISM study is called, and they enrolled 4,100 women. altogether is 10 times more than any other meta-analysis done before. And again, they didn't show, because you see the first result was very similar between progesterone and placebo. But again, when we have a woman, the message of this study was, when we have a woman which is coming to your office and she's having some symptoms of treated nerve miscarriage, if it's the first pregnancy, probably there is not too much effect. Why? Because I told you before, 70% are chromosomal abnormalities. But if she has already one story of abortion, or even 2 or 3, my progesterone management works very well. It protects 30, 40, 50% of cases. So this is the result. At the end, we put, this was the result of a prism, and these are the results if you see, if we have women with a previous history of miscarriages. So the Cochrane, and we did a part of this, as you can see here, we produced an American journal, show very clearly that now, with all this data, and we are more than, you can see here, 3,000, 4,000 cases for recurrent miscarriage and more for treated miscarriage, there is a merit to give progesterone, especially when a woman has a previous miscarriage, even she has a treated miscarriage. The majority of data comes from this study of the group of Kumarasamy, which is the Prism Promise, but this is the real. Another question is, when I have to start progesterone? Of course, if I have a patient in front of me, which tells me that she has already suffered 2 miscarriages, I have to give progesterone as early as possible to this person, to this woman, from the luteal phase already, to support the luteal phase onwards. And this has been demonstrated by this other systematic review, which comprise 26,000 women. So there is no doubt that we have to start progesterone very early. This suggestion has been taken by major society like ESRE, European Society of Human Reproduction, in saying that the progesterone should be administered from luteal phase in order to prevent recurrent miscarriage. There is a biological plausibility for this. This has been demonstrated by this very elegant study of a group of Stevenson in Chicago. As I told before, one of the things that does progesterone is to prepare the enzymatic activities around the endometrium to favor implantation. One of the markers of this activity is the encyclin E, expression, which is here demonstrated by immunohistological specimen. This group have evaluated, of course, in women with IVF, because otherwise it's not easy to find a population for this, that if I have low progesterone, I don't repress the expression of this enzyme, which is fighting against implantation. This enzyme is contrary to implantation. So I have to de-repress the enzyme. But if I have progesterone in high quantity, in the right amount, or I give progesterone micronized in those which are deficient, the enzyme is de-repressed and I have implantation. So the result of the study was very elegant, is that I should start from the luteal phase because I have to modify the enzyme in order to favor implantation from the beginning. Because implantation is completely correlated to the placental bed formation afterwards. So if I have a nice implantation, after I will have a good placenta formation. Synthetic progestin do something on this? No, unfortunately not. This is a study which came out last December, you can see, and published in Human Reproduction. If I use progestins like the hydrogesterone, I don't have the same effect. I have no effect practically. The meta-analysis for recurrent miscarriage now is giving evidence that progesterone can work. There are safety concerns for this. I think that there will be, Dr. Piette will speak a little bit more about safety concern, but all the studies which have been done, because of course you may say, oh, I give progesterone from the very early beginning when I have an embryo development, when I have a growth of a fetus, may affect something. 12,000 cases evaluated in the long run, so after neonatal period and so on, no safety concern. While for instance, progestins, which are used, now there are rising safety concerns of 2 kinds, especially the risk of increasing cardiovascular anomalies in the fetus. This is a study which came out, not only the risk of cardiovascular anomalies, but also the risk of spina bifida is augmented. Of course, the risk of spina bifida can overcome by giving folic acid, but not many recall this, and this is another risk. But because some of the progestins affect the metabolism of folic acid. But in the case of, for instance, this expert review, there is an increase, you can see here very clear, of cardiovascular anomalies in the fetus for those women which have been treated from the luteal phase with this kind of compounds. So I think that, and also there are some report of hepatic failure using this kind of compounds. So I think that for the sake of safety, we have to, as a precautionary principle, use the drug which has no safety concern. And you can see that in some countries like Switzerland and France, some progestins has been contraindicated in using pregnancy because of this alert. Okay, so this is very important. This is very recent data, last year or beginning of this year. So my take message for this part is epidemiology of miscarriage is a mix of several factors, of which also environment has its role, but don't forget the psychological consequences of women can be very high. In the sporadic miscarriage, the indication now is to give progesterone if there is a previous history, at least of one miscarriage, and of course, the treatment and the workup can be done with excluding a patient with phospholipid syndrome and so on, because in this case, they should be given aspirin heparin to this woman, or in the case of high TSH, which is now considered to be more than 2.5 international unit, we should start treatment with thyroid hormones. Conclusion of this part is that it is very frequent that we face with these women. We have to be very supportive, and we have now an increasing accepted role of progesterone in, of course, based on the most recent studies which have been just summarized. For thrombophilic patient, when you screen for thrombophilia, then no way to give, to start from the beginning giving aspirin and heparin. And of course, the steroids are still debated, although patients which are in autoimmunity are counseled to continue steroids, at least for the beginning of pregnancy, if they are under steroids. Vaginal micronized progesterone in luteal phase, yes, because efficient, is safe for the mother, is safe for the fetus. There is a strong biological plausibility, as I said. Optimal dose and route administration should be selected, but remember that it should be high doses. Otherwise, there is not too much effect. And we are safe also from the neonatal point of view. So the amount that you have to give is on the base of 800 milligrams a day. So 2 divided in two times in the morning and the evening is much better, because the half-life of progesterone, micronized for instance, 14 hours. So if you give twice a day, you cover all the day with a very good amount of progesterone. Of course, it's very frustrating to fight against recurrent abortion, but remember that it should not be frustrating for us and should not push the doctor to recommend unsubstantiated therapies and tests. This is most important. Let me go more briefly to the second part, which is preterm birth. So when we think that the baby can survive, and therefore risk factor more or less are very similar to especially the abortion of the late abortion, because there are not so many genetics in this. But the concept which we should have about the prematurity is that there is a pathological activation of the same mechanism which bring a normal term labor, because the terminal pathway is the same. So if I have a uterine overdistension because there are twins, or there are vascular disorder, or there is an infection, so on, everything activated the amnion chorion decidua. part, which is the one, as you can see here, that produce all the prostaglandins and all the proteases which are capable to activate contractility and to change the cervical, milieu. The risk factors of preterm birth, we know better because, of course, there is much more attention in the risk factor for preterm birth than for abortion, can be recognized already before pregnancy in a woman. There are already characteristics of a woman which can tell us that that particular woman is unable to bring pregnancy at term. Because of genetics, yes. There are some genetics predisposition. There are family trends in having many preterm birth. There are ethnic groups, for instance, the black population deliver earlier than the white, Caucasian. There is the age of a woman, the limits of reproductive age, teenager or over 40s, they have much more chance to have a shorter pregnancy. There are many maternal disorders. Again, environmental factor, epigenetics make a part. There have been demonstration, for instance, in some countries in which they've been introduced some pesticides that the prematurity rate goes up very high because these pesticides affect the environment, affect the placental function, particularly increasing oxidative stress, and they decrease the function of the placenta, so the fetus is delivered before. And we know that one of the general risk factors in any woman to have a preterm delivery is to have a previous pregnancy with preterm delivery. Okay, this is something that we can recognize before, which we are able to do something or not, that is questionable. But at least this is something that we know before. During pregnancy, it's more difficult to act because we may have stress, we may have cervical insufficiency. Now we can discuss to put a cerclage or not. Uterine overdistension, you cannot change the number of fetuses if there are two. Uteroplacental ischemia is already late because of placental bed formation is already over. And inflammation infection, of course, we can do in the detection of microbiological specimen in the vagina and cervix and try to take care of this. All these, as I said, are able to activate the mechanism for labor, therefore determining a preterm birth. What I want to tell you, because we are in country with, let's say, high income countries, we published a study 5 years ago based on 4 million singletons evaluated on risk factor for preterm birth. And what you can see from this report, that you may have this factor in pregnancy, like hypertension, diabetes, which have high individual risk because they increase the risk by 5 times. But in general, the prevalence in the population is not so high. So the absolute number of preterm birth is not so high because there is hypertension in pregnancy. But the absolute number of preterm birth is much higher because of maternal age, because of obesity, because of educational poverty. Because, for instance, we have a lot of cesarean section, and a previous cesarean section is a risk factor for the next spontaneous preterm birth. So if I have a 40% of cesarean section in the country, and I consider that woman may have another pregnancy, that woman is at risk of preterm birth. And the number absolute of this population, although the individual risk may be low, is very high. So I have to to combine my activities as a professional person with the society changes, or at least the general view changes. Because if I don't change some health factors in the society, I will not get a result in decreasing preterm birth, for sure. For instance, the United States has probably one of the highest rate of prematurity in the world. You know about that, which is strange because you say, oh, a country which has probably very good health system. No, they have 12% of risk, which is double of the mean of Europe. And this is due by, for instance, many environmental factors. Smoking is very high in women reproductive age in United States. It has been calculated that in order to decrease at least 1 to 1.5% the preterm birth rate in the United States, you have to stop smoking or dissuade smoking women. But in order to do that, it cannot be done by only obstetrician. Of course, it should be a general view of a society to change the attitude in that case. And it is something difficult, you know. Now, the strategy of prevention which had prevailed in the last 20 years were mainly, you know, directed on 3 factors which are generally evident everywhere in the world. So these factors are present in Serbia, like in Italy, like in South America, like in Asia, which is the prior history of preterm birth, a twin pregnancy, of course, and the short cervix. Now, the short cervix became very popular in the last 20 years when we established that it's better than we not to visit anymore the patient, but let the ultrasound do the job to visit the patient for cervical length, because ultrasound are much more reliable than my fingers. Okay, my fingers can be good for, you know, evaluating some characteristic of cervix, but for the length, nothing compared to ultrasound. And everybody know that we have this cutoff of 2.5 centimeter in singleton pregnancy, which determine if I have a short cervix or a normal cervix. Okay, and of course, if I have a short cervix, I can have a previous preterm birth, or I can have twins, which make a big difference. Which tools have been evaluated in the last 20 years for, you know, addressing these risk factors? Fortunately, we are not having so much fantasy. We have progesterone, which is 90 years old. We have a cerclage, which is 75 years old, and the pessary, which has been introduced also 80 years old. Of course, they have all possible plausibility to be used, but there are not much new things coming up. Of progesterone, I already talked about the cerclage. Cerclage was introduced for cervical insufficiency. But you should know, when the authors, particularly 2 Indian surgeons, Shiroka, introduced the concept of cerclage, they introduced the concept of cervical insufficiency without giving any terminology, because if I ask to all of you, what you think is a cervical insufficiency, I will have 100 different answers. Probably the one that everybody agree is that a woman who have 2, at least, previous second trimester abortion or 2 early preterm delivery may have cervical insufficiency. Otherwise, it's very difficult to tell what is a cervical insufficiency. In any case, this became very popular, particularly in the 60s, the 70s. Everybody in the 80s was making cerclage. Then they understand that probably they do worse more than good in many cases. So we have, and then finally, this pessary, which is called Arabin, because Arabin was a German gynecologist which used for prolapse, and the daughter, okay, started using in pregnancy for you know, avoiding preterm birth in twins usually. Probably the effect of pessary is to change the angle. You see here that before the pessary, after the pessary, the angle became a little more acute. And this is something that is important, because the angle more is acute, less are the chance to deliver preterm. Okay? So a protection is to have an acute angle between the body of the uterus and the cervix. The result, I will show you the meta-analysis, of course, but these are very big studies, 35 randomized controlled trials. Everyone says, if I have a woman with a previous preterm birth, give progesterone because it works. 50% less chance to deliver preterm. But which kind of progesterone? Vaginal, intramuscular, or surrogate like 17-hydroxy? Between vaginal and intramuscular, there is a little difference. By the way, beside the compliance of the patient, he looks vaginal much better. But with the intramuscular progestogens, vaginal is much more effective and less adverse effects. And one of the adverse effects of 17-hydroxy, the famous Makina, which we don't use, but has been a long history in the United States in the last 20 years with FDA pros or FDA cons against, is to increase the risk of gestational diabetes. And a very recent paper which came out from the Endocrinological Society, that if you get 17-hydroxy progesterone for saving the mother to have a preterm delivery, you give every week for 30 weeks, then your offspring have more chance to have an early onset cancer. You remember the story of diethylstilbestrol? Diethylstilbestrol was given to protect for miscarriage, and then they discover cancer of the vagina in the adolescent 15 years later. It's not used anymore. So we have to be very careful, because this is a very important paper which just came out. So we have to be very careful to give something different from the natural compound, okay? Short cervix, as I say, the cervix short may depend from several, different reasons, intrinsic weakness or inflammation due to infection. And we can have a different way to treat. Progesterone can be a panacea, but it works at least for 30–40% of cases. This is a meta-analysis. And what is important is not only that progesterone, in this case 200 milligrams, because we are talking about pregnancy over 20 weeks, it works in protecting early preterm birth, but has a very good effect on neonatal morbidity and mortality. And this is very important because it's the first drug which shows that improving the length of pregnancy, I improve also the outcome of the baby. If you get this, for instance, tocolysis never shown the same effect. You can improve the length of pregnancy, you gain 1 week, but you never improve the outcome of the baby with tocolytic drugs. But with progesterone, yes. Okay, 17-hydroxy, fortunately, doesn't work in the short cervix, although there is a study which came out with a meta-analysis with, again, Piette and Apple, who want to say that even 17-hydroxy works in the short cervix. And we have, of course, this safety report, which is better not to use. Cervical pessary, unfortunately, it doesn't work for singletons. Or at least we don't have still the evidence. One study say yes, another study say no. And the study in which they combine cervical pessary with progesterone looks more promising. The guidelines of the European Society, which had been released 4 years ago, the last update, say that it's better to have a very good, let's say, training for putting the pessary, because I've seen putting the pessary in all the different way. It's not so easy to put the pessary if you are for the first time. And secondly, you need more careful studies that prove that it works. Cerclage for sure doesn't work alone for a case of previous preterm birth, but there is a very recent review which say that if a woman has a previous singleton spontaneous preterm birth, has a short cervix in actual pregnancy, then the value of cerclage is similar to vaginal progesterone. So it's a choice between the surgeon or the obstetrician to decide which of the two. Although I should say that, of course, the cerclage needs anesthesia, needed to convince the patient to make a stitch and so on. But these are the result of this study. Again, very difficult to compare women which are addressed to cerclage and women which are addressed to progesterone, because probably they are quite different also in the way the doctor convinced them to use one or the other. Anyhow, these are the meta-analyses which we have to rely with. And finally, twin pregnancy. If we ask to any drugs to prolong twin pregnancy, we don't have any result. But in the case that we have a twin pregnancy with a short cervix, we have a result with vaginal progesterone, okay? And again, we have a better result for neonatal outcome. And this is because one of the metabolites of progesterone is protecting the brain of the fetus. This has been demonstrated very well. I think that Dr. Piette will address this. About pessary, still the last study which has been done is showing, as you can see here from the rock curve, that is some advantage to put pessary into pregnancy. Although some other meta-analyses don't show the same result. What say the general guidelines and recommendation from all over the world, which came out in the last few years? I think that the international guidelines compendium say that the only drug, the only management we can use which has evidence is to give progesterone in all these three occasions: short cervix, history of preterm birth, twin pregnancy with a short cervix. So these are the three indications which natural progesterone can be given for avoiding at least 30 to 50% of preterm delivery in this high-risk population. I would like to end with a perspective. I don't know if you know that in thinking how to do for ameliorating some of the situation that sometimes happens in our profession, one of the most challenging is when we detect a placenta previa at 20 weeks during a morphological ultrasound evaluation. But we know that in some cases placenta migrates. So if we go 4 weeks later or 8 weeks later, the placenta is a little bit higher and is not previa anymore. Do we have, of course, this is a natural phenomenon and it's very difficult to explain how it happens. But we try in a study which we published already 3 years ago, but has been now a paper is in a publication with much more cases. We make the possibility to use pessary and progesterone when we see the placenta previa at 20-22 weeks. The reason is because the pessary divert the blood in strengthening the cervix, divert the blood, and you know the placenta follow the blood. The migration of the placenta is probably due to the fact that the blood flow of the uterine artery goes more toward the high part of the uterus, therefore the placenta go up. Otherwise, if the uterine artery blood flow may remain down, the placenta doesn't move. Doing this, we show that putting the pessary and giving progesterone, we have, you see, 2.5 more times migration than the control group, and we have 3-fold less bleeding during pregnancy, and we can have, reach almost the term of pregnancy. So this was a preliminary observation, but now we have a second study with 500 patients, and we confirm this also with Doppler findings, that if we follow the placenta which was previa at 20 weeks, and then we follow Doppler every 2 weeks, we see that giving the pessary and giving progesterone, we have a much better flow up, very low flow nearby the cervix, and therefore the placenta migrates. This is something that I leave to you to think about, and this is my final, suggestion for something new. So the take-home message is miscarriage. If we have to do something, give progesterone early luteal phase and start from early luteal phase. Treat a miscarriage, we can give progesterone if we have a woman with a previous miscarriage, at least. Otherwise, I would say there is no evidence at the moment that for the first pregnancy and treat a miscarriage, we can do something different. Short cervix in the 2 conditions, singleton twins works. Previous preterm delivery, it works, but we have to give from the beginning of pregnancy. So in this case, I think that we have a role. I would say that this is a niche of action because we cannot avoid the majority of preterm birth. But if we intervene like this, we decrease the number of preterm birth in a given area, in a given population, and we preserve the society with better outcome. Thank you very much for your attention. I think that
Want some questions now?
I better do at the end.
No, they have told me.
Okay.
So we have to thank Professor Renzo for this wonderful lecture that is based on both clinical practice and scientific research. And it is one of the most powerful things to have the scientific-based evidence for our future practice and actual one. And now I would sad bi zamolila na našem jeziku ko je raspoložen da postavi pitanje profesoru, jer dosta je tema bilo mogućnosti prevencije prevremenog porođaja, sve moći koje nudi i posebni efekti progesterona. Ko je raspoložen da postavi pitanje? Profesore, I will, okay, Olja, or me? So Olja will ask you one of the questions, after that, two of us.
Yeah.
I'm loud enough, but nevertheless. So you were talking about quite large doses, about 800 milligrams. We were like making jokes with people who were giving to their patients like 800 milligrams because all the studies were about 200 or 400 at most. When it goes up, what happened?
I assure you, there is not only the study which have been done now, which show that this is the dosage which has effect, but also there are studies which show that only if you overcome 600 milligrams, you have some concentration in blood, which are the ones useful for maintaining pregnancy, which is at least go over 10 nanogram per milliliter. If you give 400, 200, concentration blood are very low, and you don't probably saturate all the progesterone receptors of bed.
Talking about vaginal route.
Yes, vaginal
Of
dosage, yes. But the same is applied if you give a bioral dose, oral dose. While the concentration, if you give intramuscular, is completely different.
I saw so many like toxic lesions of hepatic toxic lesions with high doses of oral progesterone. And the first thing we have to do when we have something like that, we are trying to exclude all the oral preparations, all the oral drugs. So what do you think about that? Because I think it's quite, you know, big quantity of progesterone to take it orally,
yes,
and to go through the hepatic system.
But there is no need to take oral. The only reason why sometimes you may suggest to take oral is for 1 or 2 days when there is a bleeding, for instance, treating an abortion. So in this case, since a woman may be scared to put something in vagina, like a little capsule, we give for oral for 2 or 3 days. I didn't have any problem for this. And then since it's so rapid that the decrease of blood, you know, the bleeding stops in a couple of days, then you can give by vaginal route. But by far the best is to give the vaginal route, yes.
So you're suggesting or recommending to give our patients 400 milligrams
Twice a day.
Twice a day.
Yes.
So this is your recommendation.
Yeah, yeah.
I would like everybody to be clear with that,
Yes.
because
But
it is not
a,
something we are using right now. That's why.
Maybe that is because there is not to be afraid at all about it. We are using already since a few years this amount.
Yeah, well, you know, like decades ago, unfortunately, I can witness that. Nobody was afraid of 17 caprate progesterone.
Yeah.
And now you are talking about early onset cancer.
Yeah.
So we were giving like that to every pregnant woman. We also gave them, as you know, beta-mimetics and stuff like that. Now we are not allowed to do that. So I will be very cautious when I'm, you know, recommending something or talking about safety. These are, I think, the most important questions, because we are not talking about women. We are talking about onset.
Yes, no, yes,
about
you're
offspring.
right. But it has been demonstrated that on 12,000 women follow up babies until 6 years old, there is nothing giving 800 milligrams. I mean, the study which I show for safety concern, and also FDA has cleared that natural progesterone can give any effect, either teratogenic or either long-term, at least until 6-8 years of age.
6 years,
6 years of age after birth in women which have been treated with 800 milligrams until 20 weeks of gestation.
I love progesterone. Don't.
So I'm saying.
I'm just
but
because of
the
the audience.
concern,
Because I know
the concern about the other were already in keeping since a few years. The problem is that sometimes not all investigators are telling, around that there is a safety concern because they're in favor of one drug compared to the other. And for instance, Europeans have always been very skeptic about 17-hydroxyprogesterone, caproate. This is an American invention, and now they are paying the consequences. But for instance, in Italy, nobody utilized 17-hydroxyprogesterone caproate, never. So I tell you that is a little bit an attitude,
But when you're talking about prevention of preterm birth, then you are using quite lower doses.
Yes, much lower, 200.
Then it's 200, that's
Yes.
it.
But this is different, because the effect that you need for cervical length is completely different, probably is enough at vaginal level. While when you have to interact with immunotolerance and so on, that is a completely different amount of progesterone you need. Okay.
Thank you for your answers.
Okay, please.
Professor, thank you very much. I'm sure that you agree with us that all those studies that you have made till now should be done in future, and for the children, not only in the first period of life. But what do you think about the possibility effect of progesterone in later on life of female children when they come to the puberty? When they are 13 or 14 years old, something that can make the rebound effect and polycystic ovary syndrome in those female children. If their mother are getting, yes, if their mother are getting larger doses of progesterone during pregnancy. Have any studies been done as far as you know, and the part of
no, but
that kind of all the period of female children?
Can be an interesting question, but you know that nowadays the reason why there is a metabolic syndrome, polycystic ovary syndrome, is mainly linked to so-called epigenetic changes, which probably has nothing to do with the progesterone. And the fact that mother is for instance having different lifestyle, is obese, or there are wrong attitudes in the feeding, for instance, not breastfeeding, giving different kind of milk, and also high protein in the first 2 years of life. This has been linked very well with the development of disorders or endocrine system later on after puberty. And this is mainly because we now start to understand a little bit more that we are not making only by genes, but the genes should be played by players, and the players are making epigenetics. And epigenetics, unfortunately, is what we eat, the nutrients and environment, and these make a big difference later on. So it's very difficult to say that one single things can affect. And as far as I understand, a natural compound is very difficult to does this, and it never been demonstrated that project. One thing that I would like to remind is the following, that answer again to the question of earlier. Neonatologists now have some trials using progesterone in very preterm babies. You know why? Because it's protecting the brain and they have less cerebral palsy. Progesterone is converted in a compound in the brain which stabilizes the blood flow in the brain. So very teeny baby, either that the mother receives progesterone, either they give progesterone at birth, they are protected. And there were big studies in which giving high concentration progesterone, I mean grams of progesterone in adult, after a trauma, you may have less consequences of a trauma, especially for the blood and the GABA system, compared to those who didn't receive progesterone. So progesterone looks a very safe drug if it's so good also for neurological development. Okay.
Thank you very much. Anybody else? Da li neko još želi da postavi pitanje profesoru Di Renzu ili da nastavi?
Professor Di Renzo, thank you for your wonderful lecture and for giving us a new sight of recurrent pregnancy loss. And Especially you mentioned immunological factors as well as thrombophilias. I sincerely believe that there are many other factors that we will discover in the future years. And we eventually always come back to progesterone. Whatever else, we use heparin, we use corticosteroid therapy, but progesterone is the basic for recurrent pregnancy loss. And you recommended us the doses that give IVF clinics to the patients from IVF. They give them about 600 milligrams per day. Yeah. My question is, when do you stop using progesterone? At the end of the first trimester, at 12, 13, 14 weeks? And what happens when you want to prevent preterm birth in the same patient? Do you make some interval without progesterone, or just continue with 200 milligrams till the end?
This is a very nice practical question. I would say that I have to say what I think, because there is not too much sustainment in the literature about. The majority of the study has been done up to 12 weeks, but the majority of people are using until 16 weeks very high dosage, okay? So until 16, which is as a reason. At 16 weeks, most of placental bed is formed. So to maintain a high progesterone for placental bed formation is probably useful. After 16 weeks, you drop down to 200 because there is no need. Now, it is quite clear that those women who do IVF, even singleton, those women who have previous miscarriages have a high risk of preterm birth. In any case, because this is epidemiological data, very frequent. So we suggest to continue 200 until 36 weeks. But if I say that this is written in a meta-analysis or in our Bible, it's not written, but I do. If it can be of help for someone, this is what I do.
Thank you very much.
Okay, thank you.
Thank you for everything, for your wonderful lecture, for being our guest.
Poštovane kolege, zadovoljstvo mi je da sada pređemo na malo ginekologije, znači i malo primjene progesterona u ginekologiji. Mi imamo takođe jednog vrlo poznatog i ekspertnog predavača i ja ću vam u sledećem mom izlaganju nešto malo reći o njemu, upoznaću vas sa njegovim životnim radom i iskustvom. Dear lecturer, dear Paul Piette, thank you for coming. Thank you very much. And thank you for giving us a chance to hear, and thank you for sharing your very great experience in the field of chemistry of endocrinology. This time we are going to talk about the progesterone. Thank you for coming. And I am now going to tell something little about your CV, about your biography to our colleagues. Profesor Piette je direktor za naučna i medicinska pitanja od 2013. godine. Diplomirao na farmaceutskom fakultetu Univerziteta u Briselu, potom se usavršavao u doktorskim, postdoktorskim, specijalističkim i subspecijalističkim studijama. Njegova uža naučna oblast kojom se bavi jeste, kao što sam rekla, klinička i endokrinološka hemija. Specijalizira sada u oblasti zdravlja žena i muškaraca i povezano sa farmaceutskim razvojem u ovoj oblasti, brizi i savetovanju. Inače je publikovao iz ove oblasti 7 radova u karentiranim časopisima i mi ćemo u stvari danas slušati predavanje jednog vrlo iskusnog diplomiranog farmaceuta koji ima ogromno iskustvo i obučava u kursevima kliničke i endokrinološke hemije na Univerzitetu u Briselu, publikuje i specijalizira u oblasti zdravlja žena i muškaraca. koji su povezani sa farmakološkim delovanjem i najveći broj publikacija u stvari se odnosi na oblast menopauze, podrške lutealne faze u ART procedurama i programima i inače ono što nam je naš predavač rekao sebi da posjeduje sposobnost komunikacije i praktično mu je vrlo važna ta multikulturalna relacija što u osnovi i govori njegov dolazak ovde, inače govori francuski, engleski i holandski. Tako da evo imat ćemo prilike sada da čujemo interesantne lekcije o tome kako se progesteron koristi kod ginekoloških pacijenata kod problema povezanih sa disfunkcijom ciklusa. Thank you, Professor, and let's go with our lecture.
So thank you for this very nice introduction, and I want to thank the president of your scientific society and for inviting me in your beautiful country. I was here 10 years ago, and I was really surprised with all the changes in your fantastic city of Belgrade. So very happy to be there with you today. So it's not easy to take the podium after such a brilliant speaker as my good friend Giancarlo Di Renzo, but I will just try to share with you my pharmacodynamic experience, because that will probably bring some explanation to the question raised about the daily dose and so on. So my topic of today will speak about pharmacodynamics of natural micronized progesterone. So we all know since a while that progesterone is a key hormone together with estradiol in not only for pregnancy, but also for the regulation of the menstrual cycle. So progesterone is not only an important, a crucial hormone in pregnancy, but for sure it's an important hormone to regulate the cycle. But as Giancarlo was mentioning, progesterone is really important during the whole pregnancy, and you saw this figure. And that's what I want to show to you now, is how progesterone is increasing as a continuum in blood during the whole pregnancy. So it's not just a question to give progesterone before conception, for example, or to give progesterone to prevent miscarriage, but we need, at the pharmacological point of view, progesterone from the beginning of the pregnancy, even before conception, because if you don't have a regular cycle, you cannot be pregnant. So you need to have ovulatory cycles, and progesterone in the luteal phase is crucial to maintain regular cycle. But we know that progesterone is the hormone of pregnancy, so you will use progesterone for threatened and recurrent miscarriage prevention, as Giancarlo was mentioning. There are nice data also showing the link between progesterone and the endothelial function, which is probably responsible also for preeclampsia. And we have now a body of evidence showing how progesterone works in the prevention of preterm birth. So at the end of the day, as Giancarlo was mentioning, low progesterone in early pregnancy is definitely associated with threatened miscarriage, at least in euploidy pregnancies. So a lot of new data, and that's something interesting to share with you. And Giancarlo was showing all the new data. But there are a lot of publications, and that's really the reason why the current management in clinical practice changed dramatically in the last 10 years. When you look at, for example, threatened and recurrent miscarriage, and the story began with the first study result published in the New England Journal by Ari Komarazami in 2015. And then you had all the other publications that Giancarlo was mentioning. Also a very interesting publication in the British Journal of Obstetrics and Gynecology about the cost effectiveness, because we are in some countries with lower income countries than in the very rich countries, such as in the US. So cost effectiveness is also a point important to take into consideration. And we know that vaginal progesterone capsules are cost effective because they are certainly not the most expensive available. And then last but not least, the gold standard is the Cochrane review. And we have now in the most recent Cochrane review, the level 1 of evidence to show how progesterone works. But an interesting pilot study was showing that the luteal phase deficiency during a natural ovulatory cycle can be more frequent than we believe. And sometimes women which are subfertile, they will go directly to an IVF center because they cannot be pregnant. But sometimes the cause is just a luteal phase deficiency. And in this very elegant pilot study, they were showing that assisted reproductive technology can be avoided and replaced by individualizing progesterone supplementation during the luteal phase in natural cycle. So the key message from this pilot study is, first, before going to a stimulated artificial cycle in IVF, go first to correct luteal phase deficiency in a natural cycle. You will regulate the cycle, and some women will be rescued and will be pregnant before having to attend a very heavy program in assisted reproductive technology. So we published last year, or 2020, yes, last year, in the YBEO journal, all the pharmacodynamics behind this effectiveness of progesterone. And what I want to bring as a key or take-home message is that not only the tip of the molecule, natural progesterone, which is definitely different from synthetic progestogens, but also the route of administration of the molecule are two key crucial information when you try to understand the pharmacodynamic behind the effectiveness of the drug. And as it was mentioned in the previous presentation, during pregnancy, because you speak about intervention, safety is crucial, because in medicine, first of all, you don't have to harm. So I think that before looking at the efficacy data, when it goes to intervention during pregnancy, you have to look at safety. And there I can tell you that based on all the experimental data that we have, all the study on animals, and because progesterone is used such a long time ago in experimental design studies, we can say with a very good level of evidence that natural progesterone, at least the mother molecule, is safe. And that's the reason probably why it was the nature choice to take progesterone as the hormone to regulate and to prevent pregnancy losses. So safety of vaginal progesterone is crucial, and you saw these slides from Giancarlo, but I want really to insist that all those trials are placebo-controlled studies. So you cannot have a fake information about the safety profile, yes or not. Those studies were all done placebo-controlled, blinded, and we were measuring the neonatal outcomes, the health infant, and for sure the health of the mother in those patients taking blinded a placebo or progesterone. And I agree with you that we have a lack of follow-up in adults after, let's say, 6 or 8 years old. But we know that due to the pharmacological effect of progesterone, that if there was any deleterious effect of progesterone, it will happen very quickly in the early neonates or in the adolescent. But there is no reason to believe that this unsafety profile can happen later on in the adulthood. But for sure, we need more data to be sure that we are safe, and certainly when we increase the dose. But you have to know that we are using up to thousands of 1,200 milligrams of vaginal progesterone since more than 30 years in IVF. And you know, so many babies are born from IVF procedures, and until now there is no data published showing any deleterious effect, even in adults, born from ART procedure. So the molecule is very fascinating because nobody knows, but progesterone was involved with 4 Nobel Prizes. That's unique. You don't have one molecule in pharma industry where 4 Nobel Prizes were involved in the discovery of the molecule, the production of the molecule, and the clinical effectiveness. So it's a very old molecule, and probably that's the reason why we accumulated so much safety data about this molecule. So the characteristic of micronized progesterone is also important to understand. It's body identical. So in progesterone capsules, oil capsules, you have exactly the same molecule as you have as the hormone produced by the ovaries. But as you can imagine, we are not pressing ovaries to produce progesterone capsules. So it's produced from an hemisynthesis and extracted from a plant source. That's what we call an hemisynthesis. And what's important to take into consideration is that the optimal bioavailability is obtained by a micronization process in oil. That's the invention of the company who was presenting this first oil capsule for clinical studies. So the micronization in oil is important, and there is no one study showing that several formulations of progesterone, even vaginally applied by the same route of administration, are all bioequivalent. There is no data in the publication showing the bioequivalence between several progesterone vaginal formulations. So when you look at results from clinical trials like the threatened miscarriage, the Hariko Marazami study in the New England Journal, you have to look at which product was used in the study, because all those progesterone formulations, they have different pharmacodynamic and pharmacokinetic profile, because there is a huge importance of the size of the particle. If you take non-micronized progesterone, it's fully destroyed by the stomach and by the intestinal gut. So there is no bioavailability with normal progesterone. You need to micronize the particles. And if you don't have at least 95% of micronized particles, small one, lesser than 10 micrometers, it doesn't work. And the oil excipient is crucial because you don't have the same bioavailability if you go from peanut oil to sunflower oil to safflower oil, and there are plenty, or even olive oil, that are used in progesterone formulation. So you have to be very careful comparing one progesterone formulation to another. So different progestogens, and now we are speaking about the molecule, will have different activities depending the structure. And for example, you know, the digogesterone is a very close molecule from progesterone, but digogesterone is a truncated molecule. It's not a flat molecule. So 70-alpha hydroxyprogesterone in injectable or 70-alpha hydroxyprogesterone caproate are very similar molecule to progesterone, but the small differences will induce totally different metabolism, and that's what I want to show to you in the next slide. So small structural changes in the configuration of the parent molecule, the progesterone, the bioidentical progesterone, will induce considerable differences in the activity of the derivative. And you can see that also the biological activities of your active ingredient, progesterone, will depend for sure of the binding affinity to some receptors. That's something that we know since a while, extensively published. But what most of the publications are not taking into consideration is the tissue concentration of your hormone at the receptor level. So it's nice to show that one progestogen is binding the same receptor as progesterone, but if the concentration at the level of the receptor is not the same, it will not act on the same way. So not only binding affinity, but tissue concentration are crucial. And that's why, for example, this list of similar progestogen has totally different pharmacodynamic activities. And for example, progesterone is an anti-androgen, and you know that most of the progestogens first generation were derivative of testosterone, they were androgenic. Progesterone binds the aldosterone receptor. It's a natural diuretic, and that's crucial in pregnancy, because you know that during pregnancy, estradiol is increasing quite more than progesterone. So if you don't have enough progesterone to balance the effect of estradiol, you will have water retention, which is highly deleterious during pregnancy. So you need always to balance this estradiol huge production during pregnancy by sufficient amount of progesterone, because progesterone binds the aldosterone receptor. And last but not least, and that's unique for progesterone, you don't have it with any other synthetic progestogen, progesterone binds the GABA receptor. And GABA receptor, you will see, has a crucial role through the metabolism in allopregnanolone and the anxiolytic effect of progesterone. And anxiolytic effect of progesterone works not only for pregnancy, but for other general gynecological indications. So I summarized in this publication last year all the pharmacodynamic effects of progesterone when it goes to pregnancy maintenance. And we know from all the IVF studies since a while that progesterone is crucial to change the endometrium and to make a secretory transformation of the endometrium to permit optimal implantation with decidualization, vasodilatation. You have a decrease in apoptosis. So that means that your endometrium is growing to permit implantation. And last but not least, progesterone stimulates the vascular endothelial growth factor, who stimulate the production of new vessels into the endometrium to feed the baby. So that's crucial, and that's unique as for the progesterone that you don't have with other progestogens. The maternal immune response is also modulated by progesterone. You know that the baby or the fetus is an allograft for the mother. Half of the genetic material is coming from the father. So if you don't have progesterone, you will reject this allograft. And that's the key role of progesterone in the early implantation stage, is to protect the mother against a rejection of the fetus, because it's considered as a semi-allograft. We improve the uteroplacental circulation, and that's important because if you have done good blood flow in between the placenta and the mother and the fetus, you will have big problems in terms of fetal growth. So, and another concept which is totally new, we know since a while that progesterone blocks the contraction. Is it important to block the contraction in the late stage of pregnancy? Nobody knows, because as long as the contractions are not leading for premature birth, it's not a concern. But what we didn't know is that progesterone plays a crucial role during the implantation process of the embryo to block the contraction, because most of the miscarriage or the failures of implantation in the early stage of IVF procedure is because there is no enough progesterone at the endometrial level. And that's probably one of the answers why you need such a high dose of vaginal progesterone, 800 milligrams a day vaginally applied, because probably in the concentration, the tissue concentration of progesterone that you need to reach at the endometrial level and to block the contraction, which are a natural phenomenon to reject the trophoblast, to avoid that the trophoblast implantate, you need enough progesterone at the tissue level. And that is very interesting effect, which was discovered a few years ago. We know also that progesterone probably is the strongest physiological anti-inflammatory drug. If you look at the chemical formulation of progesterone, it's very close from cortisone. Cortisone, progesterone are very close steroids. So Mother Nature did a job very well. Progesterone is an anti-inflammatory drug, and all as obstetricians, we all know that delivery is an inflammatory process. It's the inflammation of the cervix, the opening and the softening of the cervix, production of a lot of inflammatory cytokines, and all those inflammatory cytokines are blocked by progesterone. as long as you have enough progesterone around the cervix in the late stage of pregnancy, as long as you have enough progesterone locally, you cannot have this production of inflammatory cytokines. So progesterone really protects the cervix against a premature inflammation. And that's also something that we discovered recently in our experimental studies. And the group of Roberto Romero also was nicely showing how progesterone is able to block the activation of effector T cells, who plays an important role in the increase of the inflammation process at the intra-amniotic cavity. And as Giancarlo was mentioning, is there where all the inflammation and the infection can take place. And you can block this inflammatory process by administrating vaginal progesterone, as Roberto Romero was showing in this experimental design, because you block the production of macrophages or activated B cells, who are all responsible to induce a pathological inflammation leading to a risk for prematurity. So we understand exactly at the biological pharmacodynamic point of view how works progesterone in the prevention of preterm birth. This is the cartoon with all the available progestogen, just to mention that you have only one natural progesterone and you have plenty of synthetic progestogen. But when it goes to intervention during pregnancy, you cannot prescribe any progestogen, because by the regulatory affairs, based on the precautionary principle, you cannot prescribe synthetic progestogens in pregnancy, because you have a lack of data on the safety part, which is crucial, as I mentioned. So all those progestogens are nicely used for hormone replacement therapy or for contraception, but they cannot be used during pregnancy. And we can exactly understand why, because when you look at the difference between progesterone and those progestogens, you can see that only progesterone is the exact duplicate of the hormone produced by the ovaries. That's why we call it, I don't like bioidentical, because bioidentical is not regulated by the agencies for medicinal products. But body identical means that they got the approval of all the regulatory agencies around the world to show how the progesterone works. So the body identical progesterone is definitely different from synthetic progestins, because they have different activities. And you have to understand why. Because in the 70s, when the pharma industry were looking at efficient progesterone or progestogens, in fact, at the time, they were only interested in contraception. So the goal to develop synthetic progestogens was just to block the ovarian axis and to block the FSH and the LH to reach contraceptive effect, which is absolutely not the role of progesterone, which on the contrary is the fertility hormone. But making some synthetic progestogens, there were a lot of unexpected side effects, because those synthetic progestogens, as I mentioned, they have different structure, different chemical molecules that will bind different receptors. So most of those synthetic progestogens are binding glucocorticoid receptors, androgen receptors, mineralocorticoid receptor, and that will induce a lot of side effects like acne, weight gain, depression, mood swings, irritability, loss of libido, fluid retention, bloating, breakthrough bleeding, and even an increase in breast cancer risk, as it was mentioned in the Women's Health Initiative study in menopausal women, giving medroxyprogesterone acetate, which is a very close molecule of progesterone, because medroxyprogesterone acetate is progesterone, but it's a derivative. So again, small difference in structure, big consequences, because MPA increase breast cancer risk, progesterone is neutral, or even if it works on the breast, it decreases the breast cancer risk. So you can definitely not compare all those molecules. You saw this cartoon from Giancarlo, but I was just showing in this figure that depending the route of administration, your progesterone blood level are totally different. So it's very difficult for you in clinical practice to monitor your patient based on progesterone blood level, because your progesterone blood level will depend the route of administration of your progesterone that you are prescribing. If you use, for example, oral progesterone, which works perfectly well, you have just to keep in mind that your blood level will be a little bit lower. So if you want to administrate, for example, 300 milligrams of progesterone, you will reach higher progesterone level, more stable when you when you apply vaginally, comparing to oral. So based on huge experience since more than 25 years that I am involved in clinical trials, I can tell you that more or less, when you speak about 600 milligrams progesterone vaginally applied, at the pharmacological point of view, the exposure is about the same as you are administrating 800 milligrams progesterone orally. So more or less 800 milligram oral is equivalent to 600 milligram vaginally. But the tolerance is totally different, because if you administrate 800 milligram by oral route in a woman who has no estradiol in the background, she will feel dizzy, drowsy, with all the side effects that you know as a woman in the early pregnancy. So it's not compliant. That's the reason why we move from oral progesterone to vaginal progesterone. Because with vaginal progesterone, you will have higher tissue levels, more stable, and you don't have those side effects at the brain level, as I will show you in the next slide. And so, as it was mentioned, applying progesterone by the vaginal route of administration makes full sense, because you bring the progesterone where it is supposed to work for pregnancy maintenance. For sure, you want to be close to the cervix for the prevention of preterm birth, or into the endometrium to optimize implantation in IVF procedure. And that was a nice cartoon from Paul de Vroij, which was one of the pioneers in IVF, the inventor of the ICSI methodology in IVF. And you can see the difference in one cartoon, that is stasis, in fact. You can see the difference between oral progesterone intake and vaginal progesterone. Comparing apples with apples, isotretinoin, vaginal oil capsules, the same formulation, the same capsule, just the only difference, one is applied vaginally, the other is applied orally. And you can see that you have more stable progesterone blood level, and that's true exactly also at the tissue level when you apply your progesterone vaginally. That's why all IVF centers are using progesterone vaginally, mostly because they can reach higher progesterone levels without peaks and valleys like with the oral route of administration, and you can reach higher tissue level. But sometimes you don't need high tissue level, such as for preterm birth, prevention, and so on. So you have to look at your route of administration in function of your indication. So is it clinically meaningful? Because I'm speaking, I'm a pharmacologist by training, I'm a clinical biologist. I know about hormone assay in blood, but I'm not a clinician. So the question is, are all those information, pharmacodynamic information, relevant, clinically meaningful? And fortunately, the answer is yes, because if, for example, you look at the anxiolytic effect of progesterone, you will see that this anti-stress effect of progesterone is key in some indication. I will show you, for example, in secondary amenorrhea, which theoretically has nothing to do with an anxiolytic effect, but you will see that's important. The diuretic effect of progesterone is crucial, because for pregnancy maintenance, if you don't balance this huge estradiol production, you will have problem. The tocolytic effect I show you was so important, not only in the late stage of pregnancy to prevent contraction, but also for the implantation. And last but not least, definitely we are moving from the world of progesterone being a sex hormone to a world where progesterone now is called a neurosteroid, because it works not only on the sexual part of the metabolism, but it works as a neurohormone into the brain. And that's important, not only for prevention of preterm birth or to decrease brain injury, as Giancarlo was mentioning, but also for HRT, because you will see that the effect on the brain in HRT are also crucial when you administrate progesterone, mostly by the oral route of administration. Again, when you look at the progesterone blood level, you can see easily that depending the route of administration, you can see in blue, if you administrate oral progesterone, your progesterone levels are quite similar if you apply progesterone by the vaginal route of administration. But the major metabolite, which is allopregnanolone, the 5-alpha-pregnanolone, is increased dramatically when you administrate the same dose of progesterone by the oral route comparing to the vaginal route. So the take-home message from this publication, which is key, is that if you want to focus on anxiolytic effect, anti-stress effect, and you will see that in some indications, very interesting, go for oral progesterone. If you don't need those brain effects and you don't need this anxiolytic effect, and you focus on implantation or prevention of preterm birth, you can use your progesterone by the vaginal route of administration. But definitely, progesterone blood levels are totally different with the same dose of progesterone in function of the route of administration. So we can say that progesterone activity on the central nervous system can be modulated by the route of administration. That's something totally new from the group of Beaulieu in Paris, published by my good friend Michael Schumacher. It's not the pilot, it's a scientist. And Michael Schumacher published in Neurobiology 2014 this nice cartoon showing, and we didn't know that until 2014, that the brain has the whole equipment to produce progesterone, the same equipment as the ovaries. So progesterone is produced into the brain. If you have a crash with a motorcycle or with vehicles, and you crash even a male, progesterone increased 200-fold in the brain. You have the same tissue level into the brain of progesterone as in the late stage of a pregnancy. So there is a huge local progesterone production, and you have all the enzymatic equipment, but the big difference in the brain versus the ovaries is that once you have allopregnanolone in the brain, the metabolism can go back to progesterone to recover in case of brain injury. And that's Mother Nature, which well, fantastic, well designed. If you have a crash, you have a trauma brain injury, you recover immediately by producing locally progesterone, because progesterone produces and accelerates the remyelinization of all your nervous system. And that's also true in neonates, because if you have premature delivery, one of the major complications of prematurity is brain injury. And you can even protect the neonates from brain injury if you have enough progesterone at the time of this premature delivery, one of the mechanisms of action of progesterone for the prevention of preterm birth. So as I was mentioning, we knew since a while that progesterone has a nice effect on the contractility in the uterus, but now we know that progesterone is also a neurohormone modulating the GABA receptor and protecting the fetal brain, for example, from hypoxia or ischemia in case of prematurity. So is it only important during pregnancy to know that progesterone has this anxiolytic effect? In fact, we published more than 40 years ago, that was my first study, where I was involved with clinical development with progesterone in 1982 with the group of Laureen Dennerstein in Australia. We did a very elegant study published in the British Medical Journal. It's the highest level of evidence. It's a double-blind, placebo crossover study. And you can see that if you apply utrogestan oral progesterone capsule orally, that's very important, 300 milligrams at bedtime, one intake, you decrease significantly the menstrual distress questionnaire, who lower the questionnaire, who better it works on premenstrual syndrome and through the anxiolytic activity. And you can see that when you cross over after washout the treatment, patient taking progesterone move to placebo and patient taking placebo move to progesterone, you cross over the effect. And so that the highest level of evidence that you can have to illustrate how important works progesterone orally administered as an anxiolytic drug. It works like a benzodiazepine. Serestat, Temesta, I don't know the brand in your country, but all those anxiolytic drugs that we are giving to old men or old women to improve sleep, you can have exactly the same effect when you administrate oral progesterone 300 milligrams at bedtime. You will improve sleep the same way. But is it interesting to improve sleep? For example, yes, probably in postmenopausal women, because postmenopausal woman has a lot of sleep problems during the menopause. But what we didn't really know is that the menstrual problems, cycles, are also strongly associated with stress. And that was a very interesting study in female students, young one, in between 18 and 25 years old. And 9 in 10 of those young patients were suffering from menstrual problems. And you know all the menstrual classical problems: dysmenorrhea, premenstrual syndrome, irregular menstruation, abnormal vaginal bleeding, amenorrhea, menorrhagia. But 39% of the responders reported high perceived stress and at 4-fold increased odds ratio for experiencing amenorrhea. So it was shown in this elegant study published 2 years ago, 3 years ago, that there is a clear relationship between menstrual irregularities and stress. And more recently, a new study from the Australian longitudinal study of women's health reported that during the height of the COVID pandemic, you can imagine how most stressed were those patients. Again, the prevalence of irregular menstrual cycles was increasing concomitantly. So there is a clear relationship with irregular cycle and stress. And that was fully supported by the National Institute of Mental Health, the NIH, showing how you can, during this COVID pandemic, you can objectively measure the change in sleep or eating patterns and the difficulty of sleeping, of concentrating in women who are exposed to a stressed situation like the COVID pandemic. Is there a link with progesterone? Definitely yes, that's a level 1 of evidence that the very recent study by Kagan in the GCM, the study where they were using in postmenopausal women an association of estradiol with micronized progesterone, and administrating this hormone replacement therapy in postmenopausal women with micronized progesterone, not with the MPA used in the Women Health Initiative study, they were nicely showing that all those menopausal women had an objective improvement in sleep. And as you may know, during the menopause in hormone replacement therapy, half of the women face sleep problems. Vasomotor symptoms hot flashes is important in menopause, but more women are suffering from sleep problems during sleep disturbances during menopause than hot flashes. And that's the reason my recommendation is definitely when you treat menopausal women, when stress or you look at an anxiolytic effect, you have preferably to administrate your progesterone by the oral route of administration, because this metabolism in allopregnanolone, because this brain effect and this nice anxiolytic effect. That was a placebo-controlled study. So again, you cannot manipulate the data. It's placebo-controlled, 12 months, and you show objectively that women are sleeping better with progesterone than without. If you look at functional hypothalamic amenorrhea, it's also a situation where those women have significantly higher depression and anxiety comparing to healthy subjects. So again, stress and anxiety is highly correlated with functional hypothalamic amenorrhea. And it's not surprising that you can use progesterone orally administered for secondary amenorrhea because it's an FDA-approved indication. Another interesting application for progesterone is the progestogen challenge test. We know this test since more than 40 years. Most of the clinicians are using synthetic progestogen, but just to remember to you that you can administer it for 3 consecutive months, progesterone 300 milligram at bedtime for 10 days, and you will have a nice so-called progestogen challenge test because it can be a nice tool to diagnose the previous impregnation by estradiol. You can imagine that if you have a withdrawal bleeding after stopping 10 days of progesterone, that means that you have enough estradiol in the background and you restore regular cycle. That's the essence of the progestogen challenge test. But if there is no bleeding when you stop your 10 days progesterone, then it means that probably you have a postmenopausal woman without estradiol anymore produced by the ovaries, or first of all, you have to think about pregnancy. That can be a woman who is pregnant. So the progestogen challenge test is a nice test to evaluate the estradiol amount in the background in those women when you don't know why they have irregular bleeding, amenorrhea, or those related problems. Oral micronized progesterone was used since more than 20 years in the US for the treatment of secondary amenorrhea. And in this study published 2 years ago, they confirmed, for example, that if you treat women with secondary amenorrhea with oral progesterone, even 6 months after restoring a regular cycle, you maintain this regular cycle for the next 6 months, meaning that the administration during 3 months of oral progesterone is able to restore the balance between the endogenous production of estradiol and progesterone, and it's able to restore regular cycle. And those women were taking in between 200 and 400 milligrams a day progesterone orally 10 days a month from the day 17 until the day 26. You have to keep in mind that if you take progesterone instead of a synthetic progestogen, you have for irregular cycle or secondary amenorrhea, I recommend to start your progesterone day 17 and not day 15. Most of the competitors, they are promoting synthetic progestogen, starting the treatment 10 days a month after the day of ovulation. If you do with progesterone, you start too early, you will induce bleeding by atrophy. So you have to wait until 17th day to start your progesterone to regulate the cycle, to be sure that you are 1 or 2 days away from the ovulation, just to avoid any bleeding problem when you start too early. So 10 days a month to regulate the cycle is perfect, but you have to initiate day 17 until 26. It was perfectly dose related. So if you administrate 200 milligrams, that can be part of the discussion we had previously, why to administrate so high dose sometimes? That's clearly that for secondary amenorrhea, for example, you need to administrate 300 or 400 milligrams by oral route of administration to get good results in comparison with the woman taking 200 milligrams, for example. And it was nicely shown that the side effects in terms of the safety that you administrate 300 or 200 milligrams orally doesn't make any difference. When you look at the pivotal study that we did in the US to get the FDA approvals for secondary amenorrhea, you can see that the daily dose of 400 milligrams, so you take 2 capsules of 200 milligrams orally at bedtime, works better than 300 milligrams to restore withdrawal bleeding and regular bleeding in women with secondary amenorrhea, and that's the official labeling and the FDA approval based on this pivotal study, confirmed by the other study published in Fertility Sterility 2010 by Auerbach, showing again that you have better results, 91% with micronized progesterone 400 milligrams, comparing to a lower dose. to remember the pivotal study with dydrogesterone published in the British Medical Journal is showing that you can restore regular bleeding in 82% of the patients. With progesterone, at the condition that you are administering 400 milligrams orally, you can reach 90% of effectiveness, or at least to be able to regulate the cycles in 9 patients in 10. Is it safe? That was a question. And again, that's a study in PCOS patients. And you can see that based on the insulin resistance, for example, you don't change the insulin resistance after the post-bleeding and the post-treatment. In this case, they were giving 200 milligrams for 7 days in PCOS patients. They compare also the safety profile of micronized progesterone with oral contraception. We know that a classical treatment, a standard of care to regulate cycles, is to administrate oral contraception. And that's a study where they compare face-to-face oral contraception with micronized progesterone in women with dysfunctional uterine bleeding. And you can see that the safety profile was in favor of micronized progesterone. So my take-home message from my presentation is that definitely the vaginal route of administration is probably the preferred route of administration when it goes about in pregnancy maintenance. So you need it from conception until delivery. So there are plenty of clinical indication during the pregnancy. And you can move from vaginal progesterone to oral progesterone in case of progesterone intolerance, if you have really drowsiness or dizziness or intolerance effect. And then keep in mind that if you administrate 600 milligrams vaginally, you have to go for 800 milligram oral to have the same kind of progesterone impregnation. The oral route can be suggested with this equivalent dose when brain effects are required, because you have this huge metabolism in allopregnanolone when you administrate progesterone by the oral route. Doesn't mean that you don't have the brain effect when you apply the progesterone vaginally, because the physiological increase in progesterone will induce also a physiological increase in allopregnanolone. But if you want to have a real active intervention on having an active anxiolytic effect, then probably the oral route of administration is better. For example, in the treatment of secondary amenorrhea or dysfunctional bleeding, the oral route is the classical standard of care in the US, 400 milligrams once a day at bedtime. Better to take it at bedtime because you improve sleep. So if you take 400 milligrams oral progesterone, take it at bedtime in one intake because you will improve sleep, which is nice as an anxiolytic effect. You can also suggest oral progesterone to decrease the contraction in the late stage of pregnancy, but it's an ongoing debate to know if it's worth to decrease contraction in the late pregnancy. The optimal doses are 300 milligram oral daily in natural cycle to restore normal cycles and to avoid to go too quickly to IVF centers. You can just regulate the cycles and you can correct luteal phase deficiency by administrating 300 milligrams of progesterone from day 17 until day 626 of a natural cycle to restore fertility. And that's the classical standard of care. Or you can use 3 times 200 milligrams vaginally applied for luteal phase support, keeping in mind that for fed cycle, for example, in frozen term embryo transfer cycle, you need probably more progesterone because there are no corpus luteum. When you do fresh cycles, you have corpus luteum, so you don't need that much progesterone. So that's the reason why 600 milligrams a day is enough. But in frozen term embryo transfer cycle, the woman is not pregnant. You have no one corpus luteum, so you have to supply the whole progesterone by exogenous intake. That's the reason why you have to take huge doses, 800 milligrams. Some centers are using 1,200 milligrams. That's why we know that the safety profile is perfect, because even some centers are using 1,500 milligrams. So the duration probably until certainly the ultrasound scan at week 7, but most of the centers in the world are using it until week 12, and that's the ongoing debate, when to stop, when to start, how much, and that we need more study to finalize the optimal regimen. For threatened and recurrent miscarriage, I think that the dose was clear. It's definitely 200 milligram twice a day, because we don't have the evidence with lower dose. So the question you raised was a very good question. Do we need to administrate 800 milligram because it's not standard of care in our country? You can continue with your low dose, but you don't have any evidence to support it. Now we have the evidence based on 2 papers in the New England Journal that 800 milligram works. Doesn't mean that sometimes 400 milligram doesn't work, but if you want to have really the evidence, you need to use 800 milligrams. For preterm birth, the evidence that we have is 200 milligram. And why probably you need lesser in preterm birth? Because it's a totally different effect. You need just to have an anti-inflammatory effect at the cervix level. And in preterm birth, you go for prevention. All those women are asymptomatic women, and they have theoretically more or less enough progesterone, but probably a lack of progesterone at the tissue level, and that's why you need an additional 200 milligram. It's totally different from implantation, where in IVF procedure, you destroy completely the ovarian axis, and you destroy completely the luteal phase in IVF procedure. And that's the reason why you need huge quantity of progesterone. And probably in threatened and recurrent miscarriage, it makes sense to increase the dose because it's a syndrome, and you have so much risk factors in threatened and recurrent miscarriage that the idea of aricomarazami was to administrate 800 milligram to be sure that it doesn't underdose the patients and having a lack of efficacy because those patients were underdosed. But we can try to do the study with 600 milligrams, and we don't have the answer until now. So for women with a short cervix, 200 milligrams once a day is the evidence-based daily dose that we use for prevention of preterm birth. I thank you for your attention.
Thank you for this very inspiring lecture, and thank you for this data about the neuro effects of progesterone in stress amenorrhea, in hormonal therapy. And okay, we are going to ask colleagues if there are some questions, and after that I'm going to ask you something I am interested in. Ima li pitanja?
Professor Zgojevic from Gynecology Obstetrics Clinic Northern Front, Belgrade. Thank you very much, Professor Renzo and Dr. Piette, for your comprehensive and elegant presentation about micronized progesterone, which is more than just progestogen, as you said, and you're giving us many novel data and information about its properties, advantages, efficiency, safety in perinatology and gynecology. Regarding your presentation, I have a question. Taking into consideration the advantages and safety of micronized progesterone compared to other progestogens, what is your opinion about the use of progesterone along with estrogens in menopausal hormone therapy? You'll probably agree that according to up-to-date investigations, micronized progesterone has many advantages. It stimulates osteoblasts. It has protective effect on cognitive function, but also it does not increase the cell proliferation in breast tissue and breast cancer risk related to glucocorticoid activity and its regulation of gene expression, which is crucial, which is of great importance with tailoring the most appropriate and safe menopausal hormone therapy. Secondly, regarding menstrual cycle disturbances, we very well understood and assumed that micronized progesterone is effective and safe alternative regarding metabolic and vascular side effects in treating menstrual cycle disturbances in young women, particularly those with stress-induced and functional oligomenorrhea and menstrual cycle disturbances due to beneficial anxiolytic effects of micronized progesterone, thanks to its active alpha metabolite allopregnanolone, GABA receptor agonist, which could be of great importance for treatment of premenstrual syndrome, as well as you said, but also in treating premenopausal women with dysfunctional uterine bleeding, which is also very important. And I think you could comment this use for the treatment of dysfunctional uterine bleeding. Is, in your opinion, from that point of view, micronized progesterone the first treatment choice in all these conditions I mentioned, and also, of course, you? And when dysfunctional uterine bleeding is an issue, would you prefer vaginal or oral route of its administration in which dose? And once more, excuse me, did you maybe compare the efficacy of another progestogen, Dienogest, with the high endometrial efficiency and endometriotropic activity versus micronized progesterone? Because there are some studies confirmed that micronized progesterone seems to be as effective as Dienogest in treating menstrual cycle disturbances, including dysfunctional uterine bleeding without adverse effects. Thank you very much.
So thank you, and to raise all those very interesting questions. And I cannot disagree with you. I fully agree that we have to think about micronized progesterone in hormone replacement therapy. My domain of expertise is including, transdermal estradiol. I'm a fan of transdermal estradiol for hormone replacement therapy. And the problem is that the Women Health Initiative study using conjugated equine estrogen in association with the worst progestogen that you can imagine on the breast and on the cardiovascular system, which is the medroxyprogesterone acetate, which, by the way, is considered as progesterone in the US. But it's totally wrong, as I was showing in my presentation. So definitely, yes, I think that the first choice as a progestogen in hormone replacement therapy should be progesterone, and for sure by oral. Why? Because when I was saying that you bring progesterone where it's supposed to work for pregnancy, close to the cervix for prevention of preterm birth, or close to the endometrium for implantation, in menopausal women, you have to treat hot flushes to prevent bone loss or to improve sleep. You don't need to put your progesterone into the cervix or into the vagina. That doesn't make any sense. So definitely the first intention for hormone replacement therapy is to use progesterone by the oral route. And again, you need very low dose comparing to pregnancy, because in menopause, the only reason to administrate progesterone is to protect the endometrium, again, the risk of hyperplasia and the proliferation of the endometrium induced by estrogen. And you do perfectly with the job with 100 milligrams progesterone orally applied, if you take it continuous combined. So my recommendation for HRT, or you take 100 milligram oral continuous combined with estradiol, or in the early stage of menopause, when you are 50, 52 years old, or you are not sure that the woman is in postmenopausal stage, then you have to start your HRT with a sequential continuous treatment. You give your estradiol for continuously 28 days a month, and you are administrating 14 days, 2 weeks, 200 milligrams of progesterone to protect the endometrium. But as you mentioned nicely, in my opinion, you are not administrating progesterone in menopausal women just to protect the endometrium. A woman is not an endometrium only. She has a brain, she has a lot of tissue. And so for me, if during the whole life you have an endogenous production of estradiol and a luteal phase with progesterone, there is no reason not to mimic the same in postmenopausal women, because you have to address the breast issue, the cardiovascular protection, and so on. And in terms of metabolic neutrality, progesterone is the best progestogen in long-term use, like for hormone replacement therapy, because progesterone doesn't increase the venous thromboembolism risk as synthetic progestogen, and you don't have all those side effects. Comparing to dienogest, I like dienogest because it works nicely on endometriosis. And one of the weaknesses of micronized progesterone is not to block the ovarian production of estrogens enough. You need 800 milligrams oral progesterone to block completely the estradiol production by the ovaries. But as I mentioned, if you take 800 milligram progesterone orally and that you block the estradiol production, you will have dizziness, drowsiness, and all the side effects that you don't want with progesterone, and that you don't have with dienogest. If you apply dienogest, you block completely the hypothalamo-pituitary axis. The ovarians are not able to produce any estradiol anymore, but you don't have all those dizziness and drowsiness effects that you have with this huge dose of micronized progesterone that you need to block the hypothalamo-pituitary axis. So if the goal is to have a contraception or to block the estradiol production endogenous, which is the case for endometriosis, then go for a synthetic progesterone. Looking at, you spoke about perimenopausal women. A big mistake is to give estrogen in perimenopausal women. Theoretically, as long as a woman is not a postmenopausal woman, she don't need estrogen. Because in yeah. But for bleeding, regulation of bleeding, I think that micronized progesterone works better in adolescents and in young girls with irregular bleeding, secondary amenorrhea, stress due to exams, or to induce regular cycles in very young girls. Then micronized progesterone is my first choice. But in the perimenopause, again, you have such a fluctuation in estradiol production by the ovaries that sometimes you need a stronger synthetic progestogen to block the ovaries and the hypothalamo-pituitary axis. And in this case, dienogest or other synthetic progestogen are probably a first intention. But in most of the case, you can regulate the cycle in the perimenopause just administering 10 days of progesterone, depending the stage of the perimenopause, because you know in this early stage, you have a shortening of the cycle, and in the late stage of the perimenopause, you have a long cycles. So progesterone sometimes is not enough to regulate the cycle in those women. But the first intention is to use it. And if you fail, you can go for more potent synthetic progesterone. But the dose is 300 milligrams, and probably better to take it at bedtime to improve sleep, because sleep is a big problem in perimenopausal women.
Thank you very much, and I think escalation that treatment absolutely should be.
Definitely. One treatment doesn't fit all.
Ima li pitanja još neko iz publike? Okay, meanwhile, my question is not so long. I will be shorter. I'm going to ask you about the metabolic effects of micronized progesterone, because you show us this nice table about the influences on the different receptors of the different types of progesterone. We use these progestogens in metabolically in PCOS, which has metabolic dysfunctions. So something about that.
So I am not an expert first in PCOS, but I can tell you that in my knowledge, PCOS patients are very difficult patients. First, there is no one risk factor for PCOS or one cause of PCOS. like for threatened miscarriage, there are a lot of underlying factors inducing PCOS. The major problem, I think, for PCOS patients is to maintain metabolic neutrality. And in this perspective, micronized progesterone is probably a very good option because you don't change the insulin resistance, which is a huge concern. And you restore regular bleeding, because amenorrhea is a big problem in PCOS patients. So, but probably in IVF centers, they are very expert in the way to manage PCOS patients. And when I speak with IVF experts, there is no one management of PCOS patients. One, they do in vitro maturation, other are giving mild stimulation, and there are plenty of ways to restore fertility, plenty. Sometimes you fail, but so PCOS patients at an endocrinologic point of view are complicated patients because a lot of underlying factors that we don't understand very well.
And sometimes if we need metabolically indifferent medications, then micronized progesterone is one of these, or contraceptives.
Absolutely, and definitely there are studies showing how safe is progesterone in PCOS patients, so that's quite reassuring for sure.
Ukoliko nema pitanja iz gledališta, odnosno od slušaoca, ja bih onda zaključila ovu sesiju i zahvalila se zaista na mnogo lepim predavanjima i konačno zadovoljstvo je da se vidimo ovako. It's a good and non-virtual way to see each other and to discuss. And maybe some discussion will be outside in our pause, in our cocktail. So let's go. Svi su pozvani na koktel, prema tome možemo nastaviti druženje. Izvolite napolju.